All right, I think we are at 8 o'clock. So we will get started. So today I am absolutely delighted to have the honor of introducing Dr. Bartels as our Grand Round speaker this morning. So as many of you know, Dr. Bartels is an associate professor and division chief of our program in rheumatology here. And she has, as we were just talking, has been here over 20 years because she completed her residency, her chief residency, her fellowship, and a master's in population health science here at University of Wisconsin. Dr. Bartels is nationally recognized as a health service researcher and implementation scientist with a research and clinical focus in the care of patients with lupus, as well as other rheumatologic diseases. And notably, her work has delved into the realms of healthcare disparities, and she has made substantial strides in developing tools and strategies to actually eliminate healthcare disparities. I think it's illustrative of the impact of her work, of how much media coverage many of her studies get when published. Just to give you a sampling of some of her areas of focus, her current research portfolio includes a Wisconsin Partnership Program grant as a co-PI on a project entitled Advancing Health Equity for Lupus Patients in Wisconsin. And in that project, what they're doing is investigating what are the 5 key steps for lupus care and trying to figure out, of those steps, which one of those has the largest impact on patient health. And once that is identified, then they will be partnering with key stakeholders, both across the state and nationally, to develop targeted interventions to improve survival and improve health equity in lupus outcomes. She's a senior mentor to Dr. Shivani Garg on her pilot project, clarifying misbeliefs about hydroxychloroquine and developing an individualized decision aid for diverse patients with lupus. So this is an implementation study designed to scale up their previously designed shared decision-making tool to expand it in various languages in order to assure that diverse populations have access to the care that they need. And I think that illustrates one of Christie's many strengths. She has been incredibly successful at creating a culture of inquiry in her division. And many of her almost 100 peer-reviewed publications include a trainee or a junior faculty as the first author or as a co-author. Likewise, her grant portfolio is rife with Christie being the senior mentor to many mentored grants with trainees and junior faculty, both in the Division of Rheumatology and outside the division and department. She is widely recognized for her outstanding mentorship and research and has received numerous awards for those skills, including the Department of Medicine Senior Faculty Excellence in Research Mentoring Award and the School of Medicine and Public Health Group on Women in Medicine and Science Excellence in Mentorship Award, just to name a few. She's also very involved nationally. Just a few highlights. She currently is the chair of the American College of Rheumatology Committee on Registries and Health IT. She co-chairs also for the American College of Rheumatology, the CDC-funded Lupus Measures Project, co-chaired the American College of Rheumatology Health Service Research National Meeting category. What I also want to point out, again, is her CV underestimates her contribution to the career development of others. She really is a tireless promoter of faculty and trainees, both within the division and outside. She is one of the best people who nominates folks, her trainees, her faculty, as well as others, for awards that come up. She places her faculty and trainees on national committees, provides them with opportunities to talk at national forums. And I think this quality, this sponsorship really makes Dr. Bartels stand out. So we are delighted to have her as our division chief. I would also add, even though Christie grew up in Iowa, as a New Yorker, I really appreciate having someone who can talk as fast as I can. So with that, please join me in welcoming Dr. Bartels as she talks about implementation science research in medicine and rheumatology, QI on steroids.
Well, thank you for that fantastic introduction, Dr. Schnapp. I really appreciated it. And I appreciate the example that you set as well in the realm of sponsorship and mentorship. So thank you again. So welcome everyone this morning to Grand Rounds. Hopefully you can grab the QR code to get, or the code to get attendance credit this morning for our virtual Grand Rounds, and we'll get kicked off. We do have this quick slide for CME talking about disclosures, but I'll show you actually my first disclosure is this, that actually no anabolic steroids were used in the preparation of this talk. But as Dr. Schnapp mentioned, I do receive a modest stipend from the American College of Rheumatology for a couple of leadership roles. Likewise, have unpaid service with the Medical Scientific Advisory Council with Lupus Foundation. And I had one a grant from Pfizer on unbranded tobacco cessation research, which you'll hear about a little bit later this morning. Just to get us kicked off is actually just a fun quote. I am not someone who is going to do amazing basic discovery science, but I really enjoy the fact that much of the work that I do and I help trainees do has some immediate practical applications. And I really like this. Louis Pasteur said, "To the person who devotes his life to science, nothing can give more happiness than increasing the number of discoveries. But his cup of joy is full when the results of his studies immediately find practical applications." And so that's where I've really focused, is things that could have some immediate practical applications. And we'll talk through those this morning. Our learning objectives today are first to help you distinguish between implementation science from quality improvement. Again, I think both can have strengths, but I'd really like to focus today to tell you a little bit more about implementation science. We'll talk about some key implementation strategies and resources. We'll contrast the actual intervention from the implementation, which both of which can be tested in trials and studies. We'll use the examples of our BP and Quick Connect projects to illustrate that. And then we'll give some local and national examples of work to advance population health and health equity that are really using both implementation science and QI strategies. And we'll talk through those, including our new ACR lupus quality measures and the UW Rheumatology clinic efforts. So to kick us off this morning, we've got Rosie the Riveter here. So again, no actual steroids used in the preparation of this talk, but I love this image from the World War II image by Miller from 1943 that shows the power of just good old-fashioned elbow grease to get things done in times of need. So we'll talk first about implementation science models and strategies, and just start off with a really basic definition. So implementation science is the study of methods that promote the adoption and integration of evidence-based practices, interventions, and policies into routine healthcare and public health settings to improve the impact on population health. So I like to really think about this as basically implementation science is the science of getting evidence into practice. So this is really something that is incredibly important. As you know, there's a classic study that quoted that it takes on average 17 years to get bench discoveries to the bedside. And again, we're just trying to think of ways that we can accelerate that process to reduce from 1 to 2 decades to get evidence to practice. This table is nice because it just shows that essentially the focus of quality improvement is really thinking about a specific patient level problem within a single system. And the goal is really to fix that problem in that system or in that clinic. The approach, as many of you know, is often with these PDSA cycles, things that are plan, do, study, act. And you really think about local strategies that could improve the problem at that local site. Now, there are a few models that can lend themselves to QI, or maybe even many models that lend themselves to QI. And many of you have heard things like the Lean program from Toyota or the Six Sigma program that can help with quality improvement. But again, the focus here is site specific. And when we broaden out to implementation science, we sometimes use some strategies from the QI world, but really we're thinking broader. We're thinking about getting those evidence-based gaps, addressing those evidence-based gaps across systems. We're thinking about generating generalizable knowledge that also can improve quality. And when we're designing the trial, we're often designing a trial with a fixed implementation plan or studying comparing a couple of implementation strategies to really think about the way that we could scale and improve a problem across sites. Now, often, as you might imagine, this actually requires and benefits from having a scalable plan that often requires grant funding. And within that grant, it's often anchored around models such as the Paris framework or the REAIM framework or other implementation models. And I'm going to tell you about a few of those this morning that I think can be incredibly helpful. But likewise, it's really thinking about things like behavior change models, because as we all know, that can be really a challenge, and keeping that front and center can definitely help with local efforts, and also when thinking about something that will be a scalable strategy across systems. So the first model that I'm going to talk about this morning is the Paris model. And this model is actually reflecting work of the person featured in the picture here, Dr. Edmund Ramley, who was an engineering faculty here at UW, who recently went to Indiana University. Dr. Ramley and I collaborated for nearly a decade, and really he was one of the people who underscored to me that you can't just build an intervention and expect outcomes, right? We've struck through that we really need to think about what is it about the innovation that might make it worthy of uptake. What is it about facilitation? How are we supporting people in context to do that new process versus their tried and true methods? And in that context model, you'll see that there's 5 different realms there. And that thinking about the person, the place, the tools, the technology, and the policies. And that actually reflects the SEEPS model of Dr. Pascal Carrion, another UW now emeritus professor from the School of Engineering, who really kind of made us think through how we would implement in settings, in healthcare settings, and facilitate that change. And then it's only after thinking about those 3 considerations that we can really expect to change processes and ultimately to change outcomes. And so again, I think this is a good schematic to make us think a little bit more about how we can achieve change in our practice settings. On a bit more complicated note, but again, echoing many of the same principles, we have the CFR model, and that stands for Consolidated Framework for Implementation Research. This is a favorite of Dr. Jane Mahoney of the UW Geriatrics, who is one of the leads at the D&I Launchpad. I'll tell you a bit about later today as a central resource. But this model really talks of, again, if we start with me in the upper right, the implementation process itself, about engaging teams and tailoring strategies. Next, in the green box, it talks about the innovation and how we're going to help people try the new innovation, that it's trialable, that it's evidence-based, that it's adaptable. And then again, saying that then we can change processes and we can change individual behavior. But again, in the first purple circle, we see the inner setting that, again, this is going to be dependent on characteristics about that clinic. It's also going to be on the inner setting, and then it's also going to be dependent on factors of the outer setting, things like finance and policies and systems. And ultimately, that individual change is also going to be dependent on people's roles, their self-perceived or externally perceived roles, the barriers of facilitators in that setting. And again, in part, I show you these models not to have you memorize them, but just to say that if you're thinking about implementing something, sometimes it's helpful, A, if you're writing a grant, certainly, and B, if you're just trying to think through in advance, what areas might you be able to target to maximize success? These are some great things to think through. And then finally, there are some lovely implementation science models that really help us frame outcomes for our studies. And again, I would encourage even folks just thinking about basic QI to think about these frameworks when framing outcomes that they might measure. So the first on the left is my absolute favorite, and it's an acronym that REAIM, and the REAIM framework came from Glasgow and colleagues, and it really frames that we want to have good reach, meaning that all the people who are eligible actually receive the intervention. We want to have good efficacy, obviously. We want high adoption by the end users for the intervention. We want implementation fidelity. And finally, we want it to be maintained over time. And that final blue box on the left really shows a principle, I think, that's been highlighted as Rose's principle. And I love this. And this is basically making the point that if you have something that has broad reach across a population, even with medium efficacy, you can get a huge population level impact. And I think sometimes we think about these complex clinical trials that have many, many components, but maybe they can only reach, 100 patients. That I think it's good to come back to this basic math and basic concept that, again, if we can get something that's replicable across a population, we can, again, have a huge impact without constraining ourselves with a deeper dive thing that has high efficacy, but is really difficult to replicate. On the right, we see the work of Dr. Enola Proctor, another fantastic implementation scientist who expands this implementation outcome list just a bit. So again, if there are things that you want to pick up here, there would be ideas such as testing the feasibility, the cost, and again, this idea of sustainability or maintenance, which again, you'll hear some of these themes echoed through the work that we'll share with you today too. And finally, as we finish up our primer on implementation science, resources and key tools, this is a study by Waltz and colleagues that was published in Implementation Science that talked about the expert recommendations for implementing change or the ERIC strategies. And she characterized these as a go in a go zone. And so many of you who do QI have heard the term pick chart, where we actually want things that are highly important and highly feasible. And those are the things we should probably tackle first when we're thinking about that. In Waltz's work, she highlighted that things should be, again, highly important, highly feasible, and circles this in this green box here. She characterizes in the study actually nearly 90 different strategies that one could use as implementation strategies, but then really highlights the ones that are in that upper go zone as things that should definitely be used when we're thinking about implementation plans. And interestingly, here on the slide, I just highlighted some of the ones that we've used over the years in our BP and Quick Connect. We've used over 27 of the strategies. And again, most of these are from this go zone. So if you're looking for an implementation plan, I would strongly encourage you to pull this classic article and think through things like tailoring to your setting, things like engaging a change team, building a coalition, making the education didactic, but also developing some teach back methods and lots of other specifics that are using audit feedback, and many other specific things are highlighted in this fantastic list. All right, and now we'll jump into some examples. So again, here we've got another picture of a Rosie the Riveter, but here it's a pandemic era Rosie. Again, some of the implementations that we did were during the pandemic, and we figured this is a way to truly stress test the interventions, that if they work during the pandemic, they were really going to work. So I'll tell you a bit about our BP and Quick Connect programs. So first of all, I'm just going to frame us to kind of anchor us on my internal motivation. I became a rheumatologist at a time when we had fantastic medications that were incredibly expensive, but incredibly effective in things like rheumatoid arthritis. And yet we knew that patients would continue to have some loss of years of life, typically due to cardiovascular disease. So this is a study that was recently published, a 2023 meta-analysis that really highlights that, for instance, lupus has 2.5 times the rate of major cardiac events. Psoriasis, again, a higher rate of major cardiac events, and then down at the bottom, 1.67 odds ratio for rheumatoid arthritis for things like myocardial infarction, stroke, and cardiac mortality. So again, despite these fantastic new treatments, we're continuing to see cardiovascular disease. And that was really incredibly motivating for me to say, what can we do, or what are we missing that we could do better? Now, obviously, as a specialist, I am not a cardiologist, I'm not a primary care doctor, and I need to convince my colleagues and peers that doing something is important. So what's the something we can do? Well, really the anchoring slide here that I've shared a number of times in a number of settings that's been incredibly compelling to people is this great work by the Centers for Disease Control. And they did a study where they looked at the percent of service use and the number of early deaths prevented. And they were able to demonstrate that hypertension was far and away the winner here, that if we could get percent of patients treated to just improve by 5%, we could save 10,000 lives. Now, by contrast, I want you to look to the far right here at pneumococcal vaccine and see that if we nearly ace the test and we have nearly perfect pneumococcal vaccination, we save about 2,000 to 3,000 lives. So really this points to the fact that if we could all get on board in specialty clinics to help get patients with high blood pressure back to settings where they can get treated or being a part of that solution, we could really make a great population level impact. And the second target that we selected was smoking cessation, because again, you can see a huge slope here showing a good return on investment. So again, starting with an evidence-based practice and implementation science, we started in the primary care literature, which included this 2013 study from JAMA, from the Kaiser Permanente group, where they really demonstrated that a blood pressure protocol that could be used by frontline nursing and medical assistant staff improved population level trends in hypertension to achieve blood pressure control. So again, the staff protocol in primary care worked. It improved hypertension control, but our question was, would this work in specialty clinics? Around this time, the guidelines also changed. And here I'll just point out that we chose to focus in on stage 2 hypertension or greater than 140/90 to stay a bit out of the fray from the debates that were coming from family medicine and a few other, maybe even geriatrics and a few other fields where they were really kind of debating these kind of other lower blood pressures. So we really focused in here because the AHA guidelines and ACC guidelines were very clear that people who were in the 140 or 90 range needed reassessment within a month. So we focused here where we could systematically follow up patients who were in the elevated blood pressure range and follow with guideline concordant care. And our BP Connect intervention was born out of actually a number of focus groups with MAs and nurses and was really co-developed. And I, in the interest of time, will not tell you all about that development. But what I'll tell you is that we ultimately came with a 3-step process. And we said that we needed to check with an EHR alert that would cue us to remeasure if the first blood pressure was high. We needed to advise and connect patients with blood pressure about the risk in rheumatic disease specifically. And then we needed to connect them to someone who actually would do something about this. And in this case, we had talked with folks at UW, and the idea was that we could queue orders for them to follow up back in a primary care clinic if they were confirmed to have a high blood pressure. Our research question was whether BP Connect would improve timely primary care follow-up after high blood pressures compared to usual care. And then we secondarily wanted to know if this might actually improve population level trends in blood pressure, though we weren't sure we were powered for this initially. So the BP Connect intervention actually includes 2 best practice alerts. The first alert comes if the patient has a pressure greater than or equal to 140/90, telling you to go ahead, the MA, to go ahead and remeasure that pressure. If that's confirmed high, a second alert asks them to open an order set. And the order set actually has these beautiful talking points that medical assistants actually gave to us and helped us develop because they wanted to really have the language to be able to have this conversation and to have it relatively efficiently. So there's a couple things I want to highlight in our order set here too. The smart set is actually smart enough to tell the patient if they're markedly high, it actually cues to alert the physician to make sure that they're not having a hypertensive emergency. But actually, again, if they're in the low elevation range between 140 and 160, it'll offer that it could be a primary care provider or a nurse visit within 2 to 4 weeks. So again, a range here versus if they're greater than 160/80, it actually specifically asks for a provider, knowing that we probably need some prescribing in that follow-up visit as well. So that was the first step. The second step is that they just document whether the patient accepts follow-up, declines follow-up, or already has an appointment within that 4-week time frame. And then lastly, they can check a box that they provided a brochure that, again, we co-developed with patients and staff to really highlight the blood pressure. The next piece that I shared with you earlier is that, again, we can't just expect to have this great intervention in the EMR and have people uptake it. So again, here we needed a tailored implementation strategy. And we had a number of components here, but the key components were that we engaged staff in co-designing and tailoring this intervention. We did this through focus groups and later through checklist tailoring, where we gave them discrete choices on how they wanted to implement this in their setting. Secondly, we educated staff. So we had them practice and refresh on how to get a proper blood pressure measurement. We also had them practice those talking points that we just talked about and the steps with the EMR workflow. We had them do that in a test environment with HealthLink staff. Next, we had built those EMR reminders, as I mentioned earlier. And then finally, we offered audit feedback, which actually we've studied in a couple of different realms here. And I have a publication at the bottom from the audit feedback learnings we have from this project. But we've done individual audit feedback. We've done group audit feedback. And again, we anchored this in a behavior theory so that we could really motivate people for that behavior change. We did this for 6 months at the beginning of the intervention and then have done this by email for some sustainability. If you look from bottom to top here, this actually spells free. So feedback, remind, educate, engage. And this was our basic strategy. And you'll see this echoed in the next intervention as well. So what did this yield? Well, ultimately, again, our primary endpoint was timely follow-up of high blood pressures. And what we were able to see in the first 6-month study was that actually we doubled the rate of timely follow-up. And this is in an adjusted model adjusting for all patient sociodemographics. And the great thing was that when we looked at sustainability out to 18 months, we actually saw an increase in the amplitude jump of timely follow-up, which was fantastic. And then the final thing that was really exciting was that not only did everyone benefit, but in fact, we saw a reduction of disparities where patients of Black race benefited even more. So again, systematic care helps us improve care delivery, but also helps us reduce disparities. And this was a great demonstration of concept. Now, that question I told you earlier was the question of whether this would actually have population level impact. And the terrific thing here was that we actually did see a population level reduction in elevated blood pressures with the introduction of the BP Connect protocol here. And I'll say this was apples to apples. These are the initial blood pressure in our clinic. And so again, we weren't prescribing in the clinic necessarily. We were just advising patients. And so again, if we think about this mechanistically, one, they were getting back to primary care. So maybe if they needed med titration, they could do that. But two, they were getting signal at every single appointment rather than us just measuring the pressure, them assuming it's normal because we don't say anything. We were giving them signal. So if they miss meds or were not adherent to their medications, again, they were getting signal at every encounter. And so this was really exciting to see, and this really motivated us to want to disseminate the BP Connect intervention. The other thing that motivated us to want to disseminate even further was that in 2019, after our initial pilot study, the AHA and ACC published what they called the structural measures for diagnosis and management of high blood pressure. And it turned out that we had already hit 8 of their 10 measures. So this is really exciting, the things with check marks here, again, indicating things we already had in mind when we developed BP Connect. So it really resonates with, again, evidence-based practice and scaling this to the specialty setting. So we'd done this in 3 rheumatology clinics at UW. And then our question was, would it work in other clinics? So we got a Wisconsin Partnership Program grant to do dissemination implementation work. So 1, we implemented in Milwaukee at a lower resource urban setting. 2, we looked at some non-rheumatology specialty clinics. We partnered with Doctors McCabe Williams and Heidi Brown, shown here at the top, and looked at it in some gynecology clinics. And then finally, we partnered with Group Health Cooperative to ask the question that among the patients we had already referred from rheumatology, when people were in rheumatology, we would schedule them with that 4-week follow-up if they had a UW PCP. But if they had an outside doc, we often just told them and printed it on the after visit summary that they should get follow-up. And so our question was really, does it work when people are across the system and have primary care and Group Health Cooperative? So again, a couple of additional advancing questions here. So first, I'll tell you a little bit about the story with the freighter intervention. So one of the interesting things is when you write a grant and then go to do the work, sometimes things have changed in the setting. And so one of the things that had changed was that Freighter had actually implemented their own institutional protocol, but their protocol did not engage their end users, did not have systematic education. It did have EHR alerts. It did not have audit feedback. It did schedule with primary care, but it did it in an asynchronous way. So again, what they did is after patients came into clinic with high blood pressures, they had a whole panel of nurses in an outreach core who tried to phone the patient to get them back in for follow-up. Now, in contrast, BP Connect, again, engages, educates, reminds, feeds back, and then we get real-time referral. So again, this was an opportunity where we decided to make lemonade and do a head-to-head comparison. So here you can see that particularly in the initial 2 months of BP Connect versus the parent protocol, we had 52 accepted offers for follow-up versus only 3 with the Freighter protocol, which was a 5-fold increase in likelihood. And then later in the protocol, we see that again, accepted offers were 46% with our protocol and only 23% even after they had some practice at that call center at Freighter. So again, showing at least a doubling of that accepted timely follow-up. So again, showing that real-time scheduling and the direct synchronous scheduling really appeared to matter. Next, as I mentioned, we work with Dr. McCabe Williams and Heidi Brown here at UW, who unfortunately both have moved beyond UW, but again, worked with a fabulous group in GYN, and we've continued to work with others in that department now, but really asking the question of whether BP Connect would work in a non-rheumatology setting. And the terrific thing was that, again, using a pre-post modeling, we were able to show, again, this doubling of timely follow-up. The other proof of concept of this is that we implemented this in 2 GYN clinics. And since then, the staff themselves have actually come to us. And in just this July, we turned it on in 3 more GYN clinics at their request. So this is just showing you that we also have high acceptability by their end users. And finally, we had that question with Group Health Cooperative. How would we fare if we just tell people to go back to primary care, but don't actually direct schedule? And here you'll see that we increase the timely follow-up from 21 to 24%, but this was not statistically significant. So again, this really underscores that we think this direct synchronous scheduling really matters. And so a group health hotline has been developed, and we're trying to work through this as well. What I can tell you is that this intervention has been sustained here at UW and also at Gunderson and at the Medical College of Wisconsin. And again, when we think through things like not only cardiovascular disease risk, but also stroke risk and also kidney disease risk in people with lupus, for instance, high blood pressure control really can make a difference. I'm going to pivot now and talk to you a little bit about the Quick Connect intervention, which is going to echo some of the themes I've already shared with you from implementation science. So Quick Connect was our intervention to look at tobacco cessation. And I love this ad, which came from the UK, where they did a campaign showing that this would be a fresh way to manage your rheumatoid arthritis, that smoking cessation, in fact, could help you with your rheumatic disease. So it turns out that the Surgeon General in the United States has actually just declared autoimmunity as the 4th area that is a smoking-related national health risk. So we all know about risk of heart disease, lung disease, cancer, but now autoimmunity has been listed within that group of things we know clearly are associated with smoking. And we also know that sometimes medications work less well in RA, and control is harder in RA and lupus. Things like hydroxychloroquine work less well in people who continue to smoke. And so we went again to people, to patients, to nurses, to build this intervention. And I love these quotes. So I'm actually going to highlight again here on the far right, Megan Piper, Department of Medicine. On the left, Dr. Andrea Gilmore, who was from School of Nursing at the time, is now with Department of Emergency Medicine, who's a fabulous mixed methods expert, who's also affiliated with geriatrics. And here we heard from patients, they had no idea. They had no idea that smoking actually, A, might make their disease worse, B, might make their meds work less well. And they were saying, boy, I spent a ton of money on these medicines, some of these medicines. If I had known, I would have quit earlier. We had nurses who said, we care, we just don't have time to follow up. And then we had MAs who again told us they just didn't have the verbiage. They didn't have the words. They ask about smoking routinely when they're checking in patients. They didn't really ask about quitting because they just didn't know where to go with it. And again, we use this listening exercise to tell us how to build the intervention. And the other thing we did is, again, went back to the literature and said, what do we know? So in the literature, we know that 70% of smokers consider smoking or quitting each year, and 40% are going to try. But it turns out that if they get advice from a physician or someone in the clinic, it dramatically increases their quit attempts. And then if they get quit support from something like a quit line, their likelihood of having 6-month abstinence or a permanent quit, again, dramatically increases between 40 and 60%. So we said, how could we get people connected to those evidence-based resources? And the fun thing was that Cochrane review showed a very similar odds ratio, whether it was a doctor giving them the advice or even a medical or a dental hygienist. So again, we knew that we could really empower our frontline staff to possibly do this work as well. And finally, you see here this fantastic study by Vadrine and colleagues from JAMA Internal Medicine, where they use this model of ask, advise, connect. And the idea here, again, was getting people connected at that point through a fax program to have the smoking cessation quit line reach out to them, versus in our setting, we actually created this through an EMR. But the point was that it's 13 times more effective than just handing a patient a brochure or just asking them to call quit line on their own accord. So really making the point that this connecting the loop makes a difference. So we went back to the drawing board, and the beautiful thing again was this really resonated with what we had done with BP Connect. We could check that using an EMR alert so that if patients were logged as smokers, we could ask them, have you thought about cutting back or quitting in the next 30 days? Then if they said yes, we could tell them, it's the best thing you can do to help your rheumatic disease and your long-term cardiopulmonary outcomes. And then finally, we could connect them. And we built an EMR interface that would go to the Wisconsin quit line so that the quit line would call the patient within 3 days. most often. The quit line would call up to 5, it would make up to 5 attempts, and then ultimately would reach the patient once and offer services, which could include coaching, which was free, and also mailing free nicotine replacement therapy to the patient at home. The terrific thing about this in clinic was that this took 10 seconds to ask about readiness to quit. If the patient wasn't ready or thinking about cutting back or quitting, we just planted the seed. And then if we needed the entire sequence, it took on average 90 seconds. So again, really fast intervention. Again, we use the same feedback, remind, educate, engage strategy that I highlighted earlier for the implementation strategy. And we really wanted to know whether we can improve quit line connectivity for cessation versus usual care. So here, the talking point was, could we have the quit line call you to discuss free coaching and nicotine replacement for the people who had said that they were interested in cutting back or quitting? If the patient said yes, we had them click the box after, and basically we would HL7 interface connect to the quit line, and then the quit line would send that result actually back to the electronic health record, which would show us that they accepted coaching, they took a 21 microgram patch, and they set a quit date, and we have all those results. And here I'm actually just going to tell you another pearl, both in the QI and implementation science space, which is we in that and those order sets, we created what we called smart data elements. So we knew the process steps were happening, and then again had these results land so that we could track the intervention using the EMR as well. So again, just showing you a little behind the scenes look on that. But the bottom line was it worked, that we increased quit line referrals by 26-fold. And interestingly here, I think this is kind of a fun little fact, is that we also increased use of that readiness to quit. It turned out that's actually in the Epic native system. And at baseline, we were using it 3% of the time. So we were just never asking patients if they thought about cutting back or quitting. So increased that by 120-fold, and then increased quit line referrals 26-fold. And to date, we've had more than 200 Wisconsin quit line referrals from rheumatology clinics. And so again, just showing that this brief intervention can really make a difference in the lives of our patients. When we asked, about a third of patients were ready to quit. When offered the referral, 71% of them took it. And then actually afterwards, a quarter of those patients reported a quit attempt. And if you think about this, the other great thing was that we partnered with C-Tree, and we were able to demonstrate that among those people who set quit attempts, 33% of them stayed quit, which is incredible. And then also, regardless of their quit status, 94% of patients were satisfied with this process. They felt respected. They felt that this was an appropriate help. And they were really grateful to hear not only, you should quit smoking, which of course they knew, but also how to do it and to get that coaching help. So this was a terrific finding that, again, we published with the team. We next then implemented at Gunderson Health System, and again had pretty similar results here. I'm highlighting in the upper right Dr. Doug White, who's now the president of the American College of Rheumatology, who's a Gunderson rheumatologist, and on the far right, Dr. Ann Shadara, who was then a fellow who helped us get the first ACR abstract from the findings of this group. But again, we were able to demonstrate that we could ask about readiness to quit, we could refer to the quit line, and have patients accept that quit line referral. Smoking cessation referrals increased 14-fold at the Gunderson Center. And again, they're continuing to use this intervention. And finally, most recently, we've done Quit Connect at the Emory Grady Health System. So some of you may know Grady is actually a public health safety net hospital in downtown Atlanta. This is Dr. Sam Lim on the left, who's the leader of one of the 5 CDC-funded lupus cohorts. On the right, Dr. Jennifer Brandt. And this population that they serve includes 78% of patients who identify as Black race, 13% who identify as Hispanic ethnicity, and over half are on public insurance, and another third are on self-pay. So again, what we would consider really a low resource setting with patients who have high rates of baseline smoking. So here at the Emory Grady, where again we implemented with their staff, we were able to increase readiness to quit asks, we increased referrals to quit line, and they actually had a de novo system in their baseline system was to offer a cessation class. And so we were actually again able to do a bit of comparative effectiveness research here, where we could see that 92% of patients accepted referral to quit line, 18% accepted referral to that Grady class, and overall, 97% of patients who indicated that they were ready to quit were willing to accept one of those 2 interventions, which is really pretty incredible. And again, we're working on getting this publication out very, very soon. So excited about that. The other piece is, again, a number of people were reached, and 37% of them had set a quit date or had a quit reported in progress. And I point out here that it actually was at the same time that nationally there was a JAMA publication that during COVID-19, cigarette sales were actually increasing for the first time since 2015, and 27% fewer nationally were seeking quit lines. So we had stress tests in a low resource setting, and also during the pandemic showing that this worked. It worked with a 20-fold increase in referrals. And one of the other interesting findings here was that at Grady, 100% of their medical assistants were actually of Black race. And it worked even better in the Black population. You'll see here, actually, interestingly, they had a pretty low white non-Hispanic population, but perhaps didn't work as well in that population. And interestingly, here raises some hypothesis generation about racial concordance, which, again, often the racial concordance of our MA frontline staff is better than our MD staff. So this may be an opportunity of why it could be particularly effective having MAs help with this effort. Finally, again, we talked about outcomes that are important in implementation science, and here just cost effectiveness. So we did just a back of the envelope. I'm proud to report that the MAs now make a better wage, but just for the sake of easy math, when we published this a few years ago, we used a $15 per hour wage, and we were able to demonstrate that each referral to the quit line cost only $1 at UW, and each quit attempt cost $15, meaning this is a very cost-effective intervention. At Grady, it was even less expensive, 40 cents per referral, and $4 per quit attempt, which really shows that this is something that could be scaled and over new settings. We showed that this worked, again, in places that had really high disadvantage. You see here on the top, Milwaukee with the red city core, the blue more affluent periphery, and again, Atlanta with the red and blue areas here, and also high current smoking rates at 17 and 19%. And we now have implemented BPA Quick Connect across respectively a total of 9 different clinics. So again, just showing the differences where we've implemented and different implementation strategies to sort of scale this over time. If you want to learn more about this, you can take a look at our Connect Health website. We have toolkits that you can download to see demos. But I want to actually also just pivot us a little bit to think about what we've been doing in the rheumatology space, both nationally and locally. So I'm going to transition us next to implementation to advance population health and health equity. And here you see that same "we can do it" spirit with Frida Kahlo when she says "si podemos." So terrific. The first thing I'm going to talk about is the national ACR measure efforts. And here we've got a Norman Rockwell depiction of Rosie. All right. So as Dr. Schnapp mentioned, I actually am the chair of the RHIT subcommittee, which helps to measure those CMS measures in rheumatology that are our quality measures. And then the first pink box here, you see tobacco screening, high blood pressure, and high blood pressure care are in those boxes. And that's what I've just been telling you about. So again, some population level in quality measures that are in the 25 current ACR measures. You can see that ACR has several measures in the rheumatoid arthritis space, has some in the psoriasis and psoriatic arthritis and gout space, but previously had no measures in lupus, even though we knew that's a major area with healthcare quality gaps and health disparities. And so I was really thrilled to be asked by the ACR to help co-chair an effort to define new quality measures, and also to work with a group that looked at patient-reported outcomes. I'll also proudly report that I'm working with Dr. Sancha Ferguson on defining equity measures across all of these measures, and really thinking about an equity lens as well. And hopefully in a future Grand Rounds, she can come back and tell you more about that effort. But in the lupus project, the objective was really, it was part of an ACR CDC funded grant, where really we wanted to work through the literature to take a look at what would be the quality measures that we could name that would have the greatest public health impact, that would reduce, again, help improve outcomes and reduce disparities for patients. So to do this, we assembled 10 lupus experts. We did a 20-year lit review of the North American literature. We created and also European literature of different guidelines. We also summoned a 17-panel Delphi member group that included people from nephrology, rheumatology. It also included some patient participants, and we voted in 3 different rounds of Delphi sessions. Again, thinking about this what would be important, what would be feasible, and what would have the biggest population health impact. And again, on the final publication, I'll proudly report that Dr. Shivani Garg was a fantastic member on this team, is also highlighted on this publication, and is also helping with the PRO measures that are still in development or still in review. Ultimately, from the quality measures perspective, what we picked was hydroxychloroquine use, limiting glucocorticoids, and monitoring creatinine and urine protein. And if we think about this, hydroxychloroquine use, we know prolongs lives, decreases cardiovascular events, and decreases clotting events or thrombosis in patients with lupus. So again, great evidence base to show and decreases major flare, hospitalization, and end organ damage. So again, great evidence to show that if we could get everyone with lupus on hydroxychloroquine, everyone without a contraindication, this could make, again, a big population level impact. Second, that limiting glucocorticoids, the goal was to get them less than 7.5 milligrams by 6 months. That even if they had a nephritis flare, we should be using steroid sparing agents to get them down and off that medication versus using that medication as a Band-Aid through the ER and other settings, because we know glucocorticoids increase risk for heart disease, diabetes, many other untoward effects. And stroke included. And then finally, again, monitoring every 6 months for creatinine and urine protein as a baseline minimum for everyone with lupus, so that we make sure that we detect and treat any new nephritis or relapse nephritis quickly and effectively. So again, next steps will be to look at equity. Next steps will be to implement these and to think about implementation strategies. And we're already starting that work, as Dr. Schnapp mentioned. I think there's a grand rounds a bit later this year where you'll hear more from Dr. Shivani Garg talking about the lupus space. So again, I tried to give a bigger overview this morning. But next, I would just like to pivot and just think a little bit more, and this actually is going to pivot us from the implementation science and population health sphere back to just the local sphere. And here we've got some pictures of some local Rosie the Riveters who were women who actually did work on those assembly lines in the Second World War. So anything to make a good internist smile on a Friday morning here. So for this, we had the task of thinking about how UW Rheumatology might be able to make advances through the 340B prescription drug savings program, which is a federal program that allows institutions that have a high proportion of patients receiving Medicare, Medicaid, to get expensive biologic drugs at a reduced cost in order that they might share those savings back to enhance care of patients who are at risk for gaps. And so when we were asked to do this, part of the piece that we really wanted to envision was how we could add both value and financial savings for UW Health. Value in the terms of what would result for our patients, our providers, our nursing teams, and really thinking about how this would affect sort of broadly. In order to do this work, we assembled a change team, and I'm thrilled again to say that Dr. Sancha Ferguson, our medical director in rheumatology, did a fantastic job helping to lead the charge here. Shelby Gomez, featured next to her, is a specialty pharmacist who's now with us in rheumatology, who really helped with boots on the ground. And on the far right, we see Kate Hartkoff and Tricia Ludwig, who were the two managers during the course of this project. On the second row, you see Mindy Jones, our medical program assistant in rheumatology, and Lori Zemlicka, our fantastic rheumatology manager. And all of us work together, again, many of the steps under Sancha's leadership, thinking about how we could work together to get that clinical pharmacist launched as of June 2022, how we could get MDs potentially shifted to sites that were eligible for this prescription savings. This is also just a little plug to let you know that we are going live at the East Madison Hospital actually on September 25th. I think I've got a typo here, but the point we were looking at was basically A, could we do this in a way that would enhance value and financial savings, and B, how would we tell the story when we get this right? So this is again a good plug that when you're doing QI projects, or if you're doing implementation science, really think thoroughly about the measures you want to collect and think about that right from the get-go. So we got pre-post survey data from providers, clinic staff, and patients, and we also collected EHR data on things like how long does it take to get prior authorizations, how many medication assistance referrals are we getting, how long is it taking to get our patients in for infusion, and how well are we doing with connecting our patients to use the UW pharmacy. So here again, if we think about measuring things, we use the questionnaire that was already going to patients about how well staff work together. So pre-implementation, we were at 77% in rheumatology, and post using the top box responsive extremely well. And post-implementation, that rose to 83.3%. And actually, I can proudly say that now we're between 86 and 91%. So we're getting a lot higher top box response. And part of this is because our nurses, our pharmacists, and our provider teams are all working together to help our patients. We were able to demonstrate numerically greater numbers of patients being referred and getting services from the medication assistance program. And also we now have pharmacists that can help with MyChart questions on meds and vaccines. And again, reflecting this staff work together experience for patients. We were also able to get better access where time to infusion decreased, and that turnaround time on PAs and number of appeals actually decreased. So again, thinking about some wins for everybody involved here, both the patients and the provider team. And then thirdly, we had evidence of improved satisfaction on scores from both providers and nurses. So staff and physician well-being increased. And this was another, again, if we think about our quadruple aim of wellness, this is another important factor. And then finally, the end result was that UW Health did have some pretty significant financial savings from the program. But again, we were able to really improve value and improve outcomes overall. So I think this is just a quick study, a story of where using a QI approach, starting with some visioning, using a change team, and then doing some rapid cycle improvement, but also thinking really thoughtfully about the measures you might look at. Ultimately, this has actually been an accepted ACR abstract that'll be presented at the ACR meeting this fall. And again, I think just illustrates again the opportunities to publish some of the terrific clinical work that's happening here at UW Health as well. And a few parting, final words. One is, I think two things when I see this picture. One is keep calm and make lemonade. So when life hands you challenges or new things to do with clinical care, I think, again, we can often make lemonade. And then we can also, as physician leaders, think about what's worse, the squeeze, or provider leaders, MAs through APPs and providers, what's worth the squeeze in our clinics? What's actually things that we think are high yield things versus maybe things that we could de-implement or things that we can do differently in our clinics. And again, I think we all can be a part of this change team. And that's really an exciting thing to me as well. So finally, here's a Rosie the Riveter statue that's in New Jersey, but I just want to share with you a few resources if you want to dive deeper and think a little bit about learning more about implementation science yourself. The first is that locally we have a fabulous ICTR dissemination implementation launchpad. I mentioned it before, Dr. Jane Mahoney, and also many other partners at the ICTR DNA Launchpad can help you. If you go to the ictar.wis.edu, you can connect to their website. You can get education resources. You can get a consult, and they also have a monthly seminar called DRIS that you can see. It's highlighted here on the second Fridays of the month that you can sign up for. And they have a Tuesday afternoon working group that Katie Miller, Sancha Ferguson, Megan Brennan, and I, and many others have come through to share some work in the working group there. And then on the right, they have an annual dissemination implementation 2-day workshop, which gets fantastic implementation science leaders of the field who to come and present. And Dr. Amy Kilborn is one of the presenters this year. Again, really fantastic lineup. So I'd encourage any of you, it's free to UW Health, our UW participants. So I'd really encourage people to come to look at this, where they're going to look at pragmatic methods to sustain impact and advance equity. So think about that this year. Nationally, the NCI is really a leader in this space. And on the far right, you can see they have a national conference that people can sign up to go to, just the implementation science conference, or on the lower right, you can see they have coursework that you can do with them as well. And finally, in summary, I hope we've really highlighted that there are a number of different behavioral frameworks you can think about to think about scalable change. You can use a lot of different implementation strategies, such as engagement, audit feedback. And again, you can look at more of those on the ICTR website or in that Go Zone paper by Waltz and colleagues. You can think a little bit about both designing interventions and designing implementation strategies. And you can think about how this might impact population health and health equity by really thinking about scalable strategies so that you can develop your own implementation science and QI superpowers. And with that, I'll thank my many collaborators, including in the far left, Dr. At the top, Monica Messina, who is my lab manager. Again, Edmund Ramley, the systems engineer who helped with many of these approaches. Again, Sancha Ferguson, our medical director, and many other people featured here, as well as the health systems that we've been able to partner with and our funders. And with that, I'll also just say a quick thanks to my family, who I'm now the shortest among them all as we pose here at the Brooklyn Bridge. But again, thrilled to have the help of my husband at home and my fantastic kids, so we can continue to further this work, both at UW and nationally through the ACR. And with that, I will take some questions.
Great. Thank you for a wonderful overview. And I love all of the Rosie the Riveter variations. Thank you. So I will start. So I love the work on smoking cessation, near and dear to my heart. There is data also suggesting that a missed opportunity is our inpatient population in terms of addressing readiness for smoking cessation. And most of them have already had a head start since we don't allow smoking inpatient. Have you thought about extending some of your interventions or looking at intervening in the inpatient population?
I love that. Thanks for that fantastic question, Lee. So one, the vascular surgery group actually has implemented the BP Connect, or excuse me, the Quick Connect program, and has that built up for their inpatient stays. And I believe Craig Comfort was interested in this for a while, and maybe, I don't know if he's on today, he can maybe speak up. In hospital medicine was interested in this idea, but certainly something that would be an opportunity. So I love that suggestion, and we could certainly advance that further. So great suggestion.
Great. And I also love how you've taken used the clinic and really built a team to improve patient care and got everyone involved. And I think it has been very successful at improving well-being of all in the clinic. So I applaud you on that, and the rest of your team as well. What do you see the bigger challenges with what policy issues, if you had to fix one thing in Wisconsin that directly impacts your work, what do you think that would be?
Wow, Lynn, this is good. This is good. A moonshot here. I love this. Yeah, this is good. I mean, I do think off the top of my head, I think the main thing that I am excited about the 340B program, that I think that actually getting patients medications is a big thing. I think that, Medicare has a 20% copay, which for these expensive medications results in $6,000 to $8,000 of out-of-pocket costs for seniors, or people who are Medicare, Medicaid duals who, fortunately, they have the Medicaid coverage, so they pay a little bit less. But I think we are really fortunate. We bargained to get 100% medication copay assistance support out of this program. And I'm really proud of that, because I think that's really something that makes a difference for keeping patients on meds like hydroxychloroquine that are critically important, but sometimes even $60 a month is expensive for a patient. So thinking about ways we can support them to stay on medications that we know have life-saving benefits. I think that's been one thing, and I'd love to be able to see if we could disseminate models like that, or change public policy so that we can reduce barriers that prevent patients from being on the right medicines versus on cheap steroid, which we know worsens outcomes. So that might be one place to start.
Great. Question from Dr. Byers-Winston. Have you conducted any intersectional data on your protocol efficacy, especially by race and gender?
I love that. And Dr. Byers-Winston, let's talk more. I love that. Let's do that. So I don't think we have looked in great detail, but I love that idea. Thank you.
All right. I think we are just about at the hour. Thank you for that wonderful overview and incredible successes at improving patient outcomes through really some, I don't want to say simple, but practical implementation. So thank you.
Thank you very much. Have a great weekend, everyone.
Take care. Bye-bye.